very much for having me here today. I feel honored to be among the guests here today. I think what probably makes me a little bit unique in this area is that I've done medical management of pain for 30 years part-time and addiction medicine for 15 years. The two groups of sets of knowledge of these two areas, they overlap a little bit, but not a whole lot. Regarding your last question, each opioid has its own specific set of side effects. One might cause more constipation. One might cause more CNS excitement because its base molecule is thebaine, which is a CNS stimulant. So it's not terribly uncommon for a patient to say, hey, I like Norco, doc, but I don't want it because it keeps me up at night. And that bunch of information comes more from the addiction side versus the pain management side. So I think that's something that has kind of helped me a little bit. Oh, I've got to figure out how to do this. Next.
I do escape and down arrow.
Escape and down arrow.
Oh.
Oh, okay. So I still practice anesthesia. And like I said, I have a company, Accessible Recovery Services. It's a pretty large company. We'll just say it's a Suboxone company. It's a medically assisted treatment company, office-based, and buprenorphine is the main drug. We prescribe. We also do use Vivitrol. The company's grown. I think we have 13 offices. We're up to about 100,000 patient visits a year, 60 physicians all across Pennsylvania. And I'm an advisor to lots of different people. All right, so our goals today, this is my one slide that didn't make it. I have Tuesdays. I do a little bit of writing every now and then, and I asked Neil Capretto, who is, I think, known by a lot of people in this room, I asked him to review one of my articles I wrote, and he said, Frank, I've taken care of tens of thousands of addiction patients. I never met one that woke up last Tuesday and said, today my goal is to get addicted to narcotics. Okay, it happens. There are brothers, our sisters, our moms, our dads, our neighbors. Everybody in this room knows somebody that's been touched by this. And occasionally I've called Neil in the past and said, this is just incredibly difficult. The bias and stigma against this patient set is terrible. And people ask what I spend most of my time doing. I spend most of my time working on the bias and stigma against these patients. You listen to other people talk, and we talked about Washington County. Washington County sadly only has, now that we're there, one practice that accepts insurance to take care of these folks. So there's a whole other side of it.
Just down arrow.
All right. Once we get back up. Okay. Well, anyway.
Just down arrow.
Down arrow, I guess. Oh, there we go. Okay. Good. One of the things I'm going to show you some pictures because pictures are fun, right? That one girl on the lower girl is. She runs our clinical operations. In our office in Philadelphia, we had a patient a few weeks ago. I can run up and say there's somebody in the bathroom at the McDonald's next door who was blue. We teach everybody how to use Narcan that we see, and we've distributed over 2,000 Narcan kits. So Nicole ran over and gave her some intranasal Narcan. Gal woke up. Paramedics were there. They came. They were rude to her. She came up to the office to thank us, and we started some treatment with her. This is the picture everybody's talking about in Hamilton County a couple of days ago. The people that overdosed in a car with a little kid in the back seat. You can look at this a lot of different ways, this picture. Some interesting things are popping up over the internet about this. And like Dr. Thomas and Kabezi pointed out, physicians and us prescribing and not taking care of these patients is something we have to look at, not just bad people. I'm sure these people love their child too. That's our Philadelphia Narcan class. How do people get money for these drugs? I just put a couple slides in here. You know how people get money for drugs? One of three ways. I'm a big three-way type person. Tricking, boosting, and flipping. We all know what tricking is, right? Boosting is stealing, and flipping is buying drugs and then selling. This little gal said there's a dentist on Broad Street in South Philly that if you let him take out a tooth and pay him $100 or $300 cash, he'll give you 250 oxycodone 30 tablets. Okay. So she says, every week I scratch a tooth till it becomes infected, and I go and I see them. But it doesn't happen at the Walgreens and CVS, but in Philadelphia, those of you that know Philly, it's a land of a lot of small pharmacies, right? So that happens. Oxycodone is number one abused prescription medication now in the United States. It has a second drug coming right behind it in some places taking over. You want to guess what that is? Suboxone. Okay, Suboxone's number two. In some counties, I think Virginia, it might actually be number one. Hey, at least I got the slide projector thing working right now. So that's, we have a team of 35 working with us. Again, we're large, we're active in clinical care, teaching, and basic research. We're huge oral fluid testing fans. I remember I presented once at the UPMC pain. I didn't present, I was actually in the audience when they were talking about urines being the gold standard of toxicology testing in high-risk patients. I put up my hand and I said, I totally disagree. And 20 people in the room turned around and looked at me. I said, witnessed urines are the gold standard. And a lot of people have done some basic studies, including us, where we took 400 patients in a row that gave us urines, and then we said, on the way out the door, we want to test your oral fluid. The results were a scattergram. In other words, no relationship whatsoever. And the people who know this are the people who are coming in to do inappropriate things, most probably to divert medications. Oral fluid testing, they sit right in front of you with a little lollipop in their mouth. The different labs do it. It costs the exact same. It probably is a protecting thing on for your practice. We have an active practice called drug school, where family practice residents, anesthesia residents, CRNP, PA students can come and stay with us for a day. So medically assisted treatment right now consists of buprenorphine, methadone, and Vivitrol. Methadone, as you know, is run by federally monitored methadone clinics. Methadone is a pure opiate agonist, which means other agonists will tack onto it. So I tell patients that when you take methadone, sometimes people try to bump their levels right when they leave a methadone clinic. Methadone has an extremely long half-life, and it has a variable half-life, which makes its conversion when it's used for pain management purposes very difficult. I think Dr. Thomas pointed out that a spike in overdose deaths about 10 years ago was because all health plans approved methadone because it costs about a penny a pill. Buprenorphine is our Suboxone and 3 other products, but that's the main ingredient. It's unique in that it's a very, very strong, has a very strong affinity for the mu receptor. So it attaches onto the opiate receptor and doesn't let anything else on unless it's overpowered. Vivitrol is the blocker. U.S. Attorney Hickton mentioned that. It tends to be used a lot through the judicial system and in jails, almost on a punitive type basis. One of the problems with the blocker, getting a Narcan shot in your butt once a month, if they're not motivated and don't want that, the dropout rates of 3 to 5 months are significant, greater than 50%. This is my favorite slide when I teach, called the Kunkel ladder. What this shows, if you can imagine opiate level in someone's body, when they have a lot of these meds in them, their level's high. When it gets below the 3rd step of the ladder, they go into withdrawal. As we talked about, that's called being dope sick. It's a very, very uncomfortable feeling. 0 is none in their body. Buprenorphine puts patients on the 3rd step of the ladder. So it's enough so they're not sick so that they can get on with their lives and hopefully do cognitive therapy and get back on the road to recovery. Methadone might put somebody on the 7th step of the ladder, but again, it's a pure agonist that other meds can add on top of. So again, Vivitrol, we have to have much better patient selection on that. It's expensive medication, right? 1 vial of it costs $1,200. Physician reimbursement for watching the patient for the month and doing the injections about $50. I'm actually working with Dr. Madden and some of the other folks in town to try to get a better way to do Vivitrol treatment, because when you have a 30% dropout rate, the medicine comes from a specialty pharmacy to us. Then they don't show up, we can't use them on another patient. So in my refrigerator in my garage, much to my wife's chagrin, I have $150,000 worth of Vivitrol. And you can't use it on other patients, so we're trying to get some way we can compassionately use it. And then we're probably going to go to a buy and bill model. So when I buy 10, I only bill the health plan when I use it to take away from the no-shows. Again, dropout rates are very high with Vivitrol, but certainly there are some patients that we have. We have about 100 patients on Vivitrol that do real well. It might be a patient, one little girl, she's in her mid-20s, she failed methadone. She said, I sold my Suboxone, my kids are getting taken away, but now she's 4 months out with this. What they'll tell you is, cravings for opiates usually last between 5 and 30 minutes. They know they have the Narcan shot in their butt so that they can push through it for the first month. Might have 3 of those episodes a day. The next month, they might only have 1 a week. Now she's at 6 months. She has her kids back, she's working, she's back in good with her family. Eventually she's going to have to choose, but over this last 6 months, she's had a lot of good cognitive behavioral therapy, worked out a lot of issues. So hopefully we'll transition her to the oral form of Narcan, Rivian, pretty soon. So it has a role, but more it seems like a role in those patients who want it. Those that come through the judicial system to make the judges happy, not so much. Okay. Buprenorphine and Suboxone can be delivered several different methods. Number one, in methadone clinics. Methadone clinics, they have to follow rules very similar to those that govern distribution of methadone at their clinic. Frequent stops per week to get it. They get take-homes if they're meeting their therapy and toxicology requirements. The second model is what's called a behavioral health model. That's regulated by the state also. These models, we have 2 or 3 real good ones in Pittsburgh. They focus on cognitive behavioral therapy. And so that the patient signs up, and maybe the first 4 weeks they have to go to IOP, their intense outpatient treatment, 4 hours a day, 3 days a week, for the first month. Then it might drop down, so it's a scale. Most of their funding comes through the behavioral component. The Suboxone physician is a minor component of their cost and reimbursement. They're a little bit limited, once again, by how many people they take on, because, again, they're spending a ton of time with the cognitive behavioral therapy. Cognitive behavioral therapy is one of the, I think, a more important thing than our medications. Don't forget, we talked a little bit about dual diagnosis in the pain patient. In the addiction patient, we're probably up to 85–90% of these patients have significant psychological disease, right? So addressing both of these things at the same time is key. Plus, I always tell patients, wouldn't it be nice if we could all talk to a therapist once a month for half an hour in total secrecy, right? These, when you talk to behavioral therapy people about HIPAA, they laugh because they're 10 times past that in what you can tell them, the security of it. And then we have office-based practices such as ours. We participate with all health plans, and our different models set up on this. Some have all-inclusive things where they do their own toxicology testing, have their own therapy in the office. Our model is that we do toxicology, but we use labs to do that, and we insist on therapy, but we're not therapists. We're the medical component. We keep check on those things, monitor the patients, and react to different situations that occur. We're very protocol driven. Now I have buprenorphine, the good, the bad. And remember, I made these slides at 3 a.m. today. So. my one administrative assistant who was with me for 2 years isn't with me anymore. So usually she has these things all looking a lot better. The good about buprenorphine, it does have excellent pharmacologic properties, right? It goes to the 3rd step of the ladder. It grabs onto that mu receptor and holds on tight. Patients will tell you if you take that, then you take some Percocet or a few bags of heroin on top, there's no effect. Now certainly it can be overpowered by higher doses of opiates, just competitive at the receptor level. But it's pretty neat that it can give you that Percocet 20 level, enough so they're not dope sick and in withdrawal, and they can get in on with their lives. It does work. We have patients not frequently. A typical heroin use is probably about $100 a day, 10 to 15 to 20 bags of heroin a day, 2 bundles a day. We've had people up to a brick a day, which is 50 bags of heroin. Yeah, they do fine. That's not, you see that not uncommonly. Everybody's real into the carfentanil that's hitting the area, right? Hamilton County and some other counties in Ohio, authorities are thinking this might be a test type run for carfentanil. Incredibly powerful. They intercepted a 2 kilogram thing through the system up in Calgary, 2 kilograms. So that's less than a 5-pound bag of flour of carfentanil that came from China. And that amount in Calgary that they got was enough to kill every person in Canada. That's how strong this stuff is. Very, very strong. And they call it an elephant tranquilizer. It's an elephant opioid. It's an incredibly strong opioid. Remember the Chechen thing back in 2002, the Russians, the theater type thing that they aerosolized something? That was carfentanil and 180 people died. They went in with standard resuscitation and they can't. I'm particularly worried about the carfentanil thing because a standard overdose, like I said, we've had 15 or 20 saves so far. You squirt Narcan in people's noses or give them a shot. In general, they wake up, so the support the airway part is not a terribly crucial thing because supporting an airway is much harder than squirting Narcan in somebody's nose. The problem with this is it's taking 15, 20 amps of Narcan to get this, so it makes the airway support critically important. And that is a much harder skill than squirting people with Narcan in the nose. The bad, street Suboxone. We see probably, 60 new patients a week, and every one of them has had this medication off the street. It is incredibly rare that somebody hasn't had street Suboxone. Now, you say, why is that? Is that because are they waiting in to get to see a good doctor that takes their insurance? Or are they using it as a bridge just between doing heroin Monday and Wednesday and not wanting to get sick on Tuesday? The exact numbers are really not known, but probably greater than 50% is used as a bridge and not just that they can't get into doctors. This drug does have a bad side. Even though it's only as strong as a 20 milligram Percocet, right? If you mix it with some Jack Daniels and some Xanax, you can overdose and die. It can push you right over the top. So it does have a dark side. Sadly, I think we've created the dark side with this medication. I think a lot like Purdue Pharma did with OxyContin and the studies and the stuff that happened that these other gentlemen talked about with its low addiction potential in giving pain patients opiates. Then OxyContin went, and we all know the whole story about that, the rapid release when you grind it and snort it, blah, blah, blah. I think we as a society had let this medicine be inappropriately prescribed for the last 10 years, and now we have a huge problem on the street with this medication. This drug is a commodity on the street. People don't realize the cartels really do control prices and quality of these drugs, right? If you look at heroin in the city of Pittsburgh, a bag of heroin costs $10. 10 bags together, it should cost $100. It's discounted to $70. 5 bundles together is, and that's about the size of a Trident gum thing. That's how much a brick of heroin. That should be $500. It's discounted to $270. Now, what's odd? Tomorrow we'll see. On Sunday we're bringing in, I think, 25 new patients at our sites. And we'll ask all 25 who get in different sites in Pittsburgh, and they'll all say 270, 270, 270. In Philadelphia, our office, it's interesting. A bundle still costs $100, but they throw in 3 or 4 more bags. So the cartels do establish this, and they control the quality. Regarding carfentanil and fentanyl, lacing with that, it's hard to imagine, but I think U.S. Attorney Hick explained this. When people hear there's something good and strong, they run for it. Right? So most of these patients say, I don't get high on my narcotics. When their level falls below the third step of the ladder, they get straighter, they get normal. Now, normal is a nice warm feeling. I had a patient I saw about 6 months ago, and a lady, I said, what brings you to me? She said, well, you heard that new fentanyl in this part of town, blah, blah, blah. Me and my husband, we ran and we got some. You run for that. I said, yeah, that would happen. She said, well, we both injected at noon and fell asleep. I woke up at 3 o'clock and he was dead, so I decided it was time to come here. I was like, whoa. She just said it so matter-of-factly, and I asked her about that, and she said, you know, when you're down this bad and you're living for this stuff and you hear something strong, you run for it. So they do run for it. We have to remember the pleasure that the dopamine gives you in your head when they take these narcotics is an incredibly warm, exciting feeling, and they want to return to that warm blanket. And when they hear there could be something stronger, they're going to run for it. Okay. Suboptimal practices have been permitted to exist, and that's absolutely terrible. We as a society have turned our blind eye. The only, and I was talking to Dr. Simmons about this, you know, I'm a big old fat white guy. I don't know what prejudice and bias is, but when I talk to people and deal with this every day, I see the bias and stigma against these patients, and it's sickening. You know, it's absolutely sickening how they're treated. So that's what we fight against every day in treating these patients. Society, again, has let these cash doctors exist, and that's sad, right? And a lot of doctors, you know, who are interested in making a lot of money, you know, they think they're working for some business guy and they're making $600 an hour seeing Suboxone patients, and they say, well, I don't have to worry, it's not my company. They don't realize that, yes, they're using your medical number to create fraud. You participate with these health plans, you are not allowed to charge these people cash. But we as a society have turned a blind eye to these people and these terrible practices out there. So 4 out of 5 Suboxone practices are suboptimal. Others use tricks like seeing patients 3-4 times a week for 5-10 seconds, 3-4 times a week, and just having them come to the office and leave scripts for them. Other practices brag that they hire a therapist to come in, and the therapist sits at a table, and they pay the therapist a little bit, but then they go for the therapy in their office and they make a lot more. Other practices do things like, we're going to charge you for your urine test today because we want to practice good medicine. They charge $30 for the dipstick test that costs $1.50, plus they're not allowed to do it. They can't do that with almost any health plan in Pennsylvania. So there's all kind of tricks, and we've let this occur. We have to stop this. It actually reminds me a little bit when HIV treatment started, how we were biased against these patients and how we looked at them really and just wanted to get away from them. We have to all get together and work together on this. You know, I don't know if those of you that follow Suboxone, the 30-100 rule just became the 30-100-275 rule, okay, which enables doctors that have prescribed buprenorphine or had this special license for 2 years to go to 275. From a business point of view, you might think I'm real excited about that. And I kind of am, because it means our team will be able to see more and we participate with health plans. But listening to the webinar from Samsa and Nina about this was a little bit disturbing, because they established criteria that have to be met by a doc to go to 275. And I really thought that they were going to hit the insurance thing hard, but they specifically came out and said, listen, you only have to participate with one insurance to qualify, only one. It doesn't have to be Medicare or Medicaid. So I'm thinking, okay, Medical Mutual Hawaii, you know, so, and then you can still charge cash. And I think we had a real opportunity here to crack down on these cash practices, and I think we are now taking a bad problem with Suboxone on the street, and I think over the next 2 to 3 years, it's going to become much, much worse. This drug certainly has to be controlled much better than it is right now. Okay. So again, never before have I seen in my 30-some years of medicine, right, Jan? It's been about 30 years. Yeah, first time I've seen Jan in 32 years since medical school. I guess this is like coming after. The thing that's interesting about this to me is we have to put all these pieces together. We have to work with law enforcement like some places are around the country, even local places, local law enforcement where they're giving patients options to get into treatment. There's a novel thing somewhere up in New England where a judge has established a system where you get into treatment and you're tested every 3 days. It's a little punitive, but he's having real good results avoiding relapses. So again, legislating this to the ground isn't going to work. We have to work with our health plans, which I'm real happy to say in Pittsburgh, our health plans have stepped up to the plate fantastically with trying to get a grip on this situation. I think President Obama, with the CARE bill, hopefully it'll get funding, right? The 1.1 billion. Guess how much we spent on betting on March Madness this year? Remember, CARE is 1.1 billion, 38 billion on March Madness. It kind of puts it in perspective a little bit for me. So we have to work together. We actually, the areas of improvement down the road are reducing the cost of treatment. Toxicology testing is incredibly expensive for these patients, often costing more than the medications and the physician visits and the therapy appointments. We have to use wiser toxicology testing when risk starts to get lower. Again, huge oral fluid testing fan. So areas for great improvement just exist tremendously. Some of these counties that everybody's mentioned, I think, we're now in Fayette County up in Uniontown. We start there this month. We're the first practice that accepts insurance. We're now in Erie. We're the first practice in Erie County that accepts insurance. Same in Oil City and same in Greenville. It's sad that a disease this profound, if this were cancer, right, or pediatric cancer, we'd be having 10K races and fundraisers, yet this affects everybody around us, and I think we just all have to get together and, not view this as a disease of people that have a problem. This is not a secondary disease, right? This is a primary disease. You don't have to be a bad bipolar to have addiction. It's not a disease specifically for lower economic class. We have doctors, lawyers in our practice. We have everybody. Certainly there's a higher incidence of this in people with lower socioeconomic groups and significant disease. So again, I call it my rainbow approach. We have to do everything. We have to educate. Jack Cabezi made a fantastic point. We cannot, as physicians, be afraid to prescribe opiates. Okay, we can't. Suicide rates among chronic pain patients over the last 12 months are up 400%. On the other hand, the other day I saw a guy that came in, a 32-year-old postal worker, whose primary care isn't writing meds for him anymore. I said, well, what does he have you on? He has me on 42 oxycodone 30s a day. 42 oxycodones a day. So the CDC guidelines had it came out, right? Because we as a medical group have not policed ourselves well. And I think these laws were put into effect to protect physicians, but certainly some bad physicians have taken over that. But anyway, when I teach drug school, I ask the young residents about what do they think about prescribing opiates. And it's, I'll never do that, I'll never do that, I'll never do that. So we have to prescribe these meds, but prescribe them incredibly safely. Like I think Steve and Jack talked about, I teach everybody 3 questions. Do you have any personal history of addiction, any family history of addiction, or significant psychiatric disease? If so, you better be cautious in prescribing these, and then you have to prescribe these medications appropriately. Go for 35% reduction in rest pain, those type of things, to stay away from high dose medications, narcotic treatment agreements, and reciting the rules. My number 1 rule, you may never, ever take tomorrow's pills today. Coordinated care with health plans, physicians, extenders. Extenders probably in November, December, they think when the CARE bill gets passed, extenders will have the ability to write for buprenorphine under a physician's number or supervision. They'll have their own X number. And my last thing I have here is Project Little Goat. What I think this city needs They need a room like this that coordinates care, a task force room where people can call. They can call to get education. They can call if somebody needs a Narcan kit. They can call if they need to get into a Suboxone or a methadone clinic or IOP or rehab. I think a lot of cities are going through this task force type model. The website that they've made is fantastic, but a real-time place where we can all call and work together on these issues. I think that would be a project. You guys know Neil Capretto, right? He's a friend of mine. He's dealing with an illness right now, but I told him if we ever get this going, this task force, I want to call it Project Capretto, and he texted me back and said, Capretto means little goat. You might want to change how that is. I'm open to questions.
Yeah, how did the Suboxone distribution system get so screwed up from the beginning, and what are the market forces there?
Well, I think a couple things happened. I think the company that made Suboxone, they went around the country and they scared physicians away from Subutex because, quote, people will inject it. Now, buprenorphine itself gets you the third step of the ladder, right? That's just Subutex. Suboxone is the buprenorphine plus Narcan. Now, what I tell patients is when you take that medicine appropriately under your tongue, that Narcan can't get in your body, it goes through, it comes out in your poop. But if you inject or snort the medication, the Narcan becomes active. So it's viewed to be a safer bet. The reality of it is, some people are injectors, right? They'll inject mud. They get half their dopamine rise from preparing the needle. So that happens, and indeed they inject Subutex, Suboxone tablets, Suboxone film, Zubsolv, and whatever. They inject them all. Okay, but those more, so that happened, that we went into that. And then sadly, I think again, because of not caring about these patients, we let cash doctors exist. We did. We let them happen. I mean, where could you go in to a surgeon or a primary care and say, I need my lisinopril script, and he says, why participate with Blue Cross Blue Shield? He said, yeah, but for lisinopril script today, give me 300. That would last about 10 minutes, right? Yet that's 4 out of 5 Suboxone practices. And again, biased against these patients, I think. But I think we're starting to wake up to that.
Is that a federal or a state or a local problem, or all?
Well, the federal government, it usually doesn't get strictly involved in those kind of things. I think it's more straight, it handled, the health plans start these things, and it takes a good while to put doctors, it takes a long, it's not simple. I talk to the health plans and they'll say, thanks for the information, we're working on it, but it's 2 years later before something happens. It's because there's a lot of laws to protect physicians, and I think some of these bad doctors practice that way. I'll be honest with you, I've been on the phone with health plans that they thought they put me on hold, and they said it's Kunkel about the junkies again. I was like, wow, so I've been there.
And it is not just a local or regional problem, it is a nationwide problem with Suboxone diversion.
Suboxone diversion is a huge problem. It's a huge problem, and it's going to get worse with this 275 rule. And the sad part is, again, we have to, there's no doubt, like U.S. Attorney and everybody else has said, medically assisted treatment is the state of the art. It's medicines plus cognitive therapy. No, you're not trading one drug for another. It's a fact. Either a methadone clinic or buprenorphine for someone that has a severe opiate addiction is the standard of care. You're not trading one drug for another. These people need to get their lives back, and you don't push them off these medications. I'll get a mom that'll come in with their 22-year-old. Their first question is, how long do they have to be on Suboxone? And I say, how long do you think I've been on a diet? No. So I tell them, if that's my kid and he's on Suboxone 10 years from now, and I can give him a hug and he's not in a casket, I'm not visiting him at the grave, I'll be happy. And I'll say, I don't want you to ever say one other word about him getting off this. It's time to get off this medication when him and his therapist think it's time. No pushing people off these meds. You don't do that. That makes patients, they'll tell you, hey, I've had a heroin problem for 30 years. I've been on Suboxone for 6 months. Don't talk about me coming off this medication. It saved my life. So, yeah.
Is there anyone working on an internet CBT program for, that would be accessible to these people? Because as you said, the CBT portion of this is
Well, right now, actually, if I would say the strong point around here, well, actually, the therapy part of this is I think, working almost near 100%. Gateway Health Plan, UPMC, they get these patients into therapy within 5 days. And also, too, the Pennsylvania Department of Welfare has an authorization process where if they don't go to therapy, they're not going to get their meds authorized. So you hate to use it as a tool or as a weapon, but it is. So I would say the strong part of this whole puzzle that we have is the therapy. Therapists are out there and they're great. And patients in general love going to them. Sometimes, Neil said sometimes, they don't want to go, but if they make their body go, their mind follows. And then they're happy to start talking to somebody.
but that's your program, but
That's statewide. I mean, if you have any Medicaid HMO in Pennsylvania, you must go to a therapist, and we give people 800 numbers, and the health plans provide that. I would really say that that's the strong point of all this.